I wanted to talk today about the challenge of opioid overdose deaths and how we might prevent those deaths, and to look critically at what we might be able to do better. So some declarations of interests. I work as a clinician in the addictions field, and I've also worked with NGO organizations and with government agencies. And we have done research both with government agencies and the pharmaceutical and tech companies. And some of that I'll be talking about in the meeting today. As the chair already told you, I head up the National Addiction Centre at King's College London, and just a bit of brief background about my own experience. The National Addiction Centre covers drugs, alcohol and tobacco research, looking across different research approaches, so from clinical trials, or population studies, or policy analysis. My own main area of work has been around heroin and opioids, but other colleagues would be doing work around cannabis, and more recently we've begun work around gambling. And the area of the translation of science into actual new approaches, into innovations, I think is at the heart of what we're interested in doing. So overall, our research would look into the causes, consequences, and influences on addictions. We've been interested in developing and pilot testing prevention or treatment interventions, and also in policy analysis, and also looking at how we can contribute to policy. And with all of that, we're then interested in teaching, whether that's master's students or postdocs. And if you have any colleagues interested in our master's courses, they're on our website. And the two main master's courses are a taught master's course, the Addiction Studies MSc, and then a distance learning master's course, which we do collaboratively with colleagues in the US and also in Australia. Okay, so for today's talk, it seemed to me that it's important for us to look at three different perspectives on the opioid overdose deaths that occur. We have to look at opportunities to prevent the overdose occurring in the first place. We then need to look at how we might detect overdose when it occurs. And then thirdly, we need to look at what intervention should occur when an overdose does happen to prevent it becoming an overdose death. So let's look first of all at prevention. There's been special interest in this because of the continued increase in opioid overdose deaths over the last couple of decades, and that's especially in North America. So these are the data from the US, and I think it's most useful for us to consider that as three different epidemics which lay on top of each other. So first of all, in these data from the Center for Disease Control, we see the increase in prescription opioid overdose deaths. So over this 15-year period, we see an approximately 3- to 4-fold increase in the number of deaths from prescription opioids. On top of that, on the right-hand side, here are the deaths from heroin overdose deaths, where we see that over the last, from about 2012 onwards, there's been a big increase in heroin overdose deaths. But then, so those two are on the left-hand side and the middle, and on the far right is the even faster increase in the number of fentanyl overdose deaths. So we have these three overlapping epidemics. And as a result of that, in the US, there are now more than 100,000 opioid overdose deaths every year. Now, just from an observational point of view and a policy point of view, it's interesting to realize that these don't just occur at random times, but there are times when we can identify a particularly high risk. And I'm just going to take you through a couple of these examples. So first of all is after a period of detoxification or after a period in drug-free rehabilitation, or at the end of somebody receiving methadone treatment or buprenorphine treatment. So that's at the end of the treatment. So these are data from a paper from a PhD student, Rosie Cornish, which was published in the BMJ more than a decade ago, looking at when do deaths occur in relation from opioid overdose in relation to when people were in methadone treatment or in opiate substitution treatment. And let me guide you through this graph. So the first point to note is that it's a log scale. So we have a log linear graph here. From this central line, at the first line, we have a doubling of it, but the top line is a 10-fold increase. And at the first point, we can see, I'm not sure. At the first point here, we can see that in the first few weeks of treatment, there is a very slight increase in overdose deaths, probably to do with people continuing with their heroin use at the same time as starting with the opiate substitution. But within a few weeks, we're down to this much healthier point, the second point, where it's a 5-fold reduction in the mortality rate. And so for all of the time that somebody's in treatment, they're at this reduced level of a 5-fold reduced rate, a risk of overdose death. But then the next two data points, where you can see that there's a 4 to 5-fold, about a 4-fold increase, those are in the first couple of weeks, the first 2 weeks, and then the third and fourth week after finishing opiate substitution treatment. So when people are taken off opiate substitution treatment, there's a brief rebound increase in overdose risk. Okay, so that's one area where we know there's a concentration of risk. The other one I'm going to just take you through is during prison release. So when people come out of prison, quite often drug-free or substantially drug-free when they come out of prison, it's assumed that they have a much lower risk of overdose death, but in fact there's a huge concentration of deaths in those first few weeks. So in this paper from my colleagues, Michael Farrell and John Marsden, they took the prison release data and they merged it with the death data from the national data sets to look at when did deaths occur and was there an increased mortality rate. And I think this is a particularly powerful bar chart. So this is the excess mortality rate in the weeks after coming out from prison. And if you look at the right-hand side of this graph, you can see that there is an excess mortality. It's above 1. So this population have an increased mortality risk throughout the year after they come out of prison. And the red or the maroon part of that bar is where it's drug-related, the deaths. So you can see that for the right-hand side of that graph, about half of their excess mortality is to do with drug-related causes, mostly overdose deaths. But the other hugely striking feature of this graph is in that first bar, which is the first week after coming out of prison, and in the second bar, which is the second week of coming out of prison, there's this huge increase in the overdose mortality rate. So that for people, most of them young adults, coming out of prison, if they have a previous history of heroin use, in the UK, 1 in 200 was dying of a heroin overdose, of an opioid overdose, in the first 2 weeks after coming out of prison. And my colleague Sheila Bird, with her colleague Elizabeth Merrill, they did a systematic review of the data to look at, was this just a feature of the UK practice or was it international? And here in this forest plot, you can see that all of the studies that had been done at the time of their systematic review, they were all finding an increased mortality rate in the first 2 weeks after coming out of prison, compared with earlier in the time. I'm going through these papers quickly, and if people want to look at them further, the slides are with the conference organizers, and I've given a picture of the slide so that you can look it up for more detail. So that's what we might be interested in observing, but it doesn't actually make any difference. We're just documenting that there's an increased mortality rate and when that mortality rate might occur. But for those of us, which I imagine is most of us, who are also interested in interventions, we want to know, well, is there something that as doctors or as other professions working in this field, are there interventions we can think of that would make a difference? And one of the challenges is how do we know what's an alert system if someone has an overdose? If they are alone, then how does anybody know they're having an overdose? Or even if they're in the company of others who are getting intoxicated themselves, how do they know that one of the people in their group is in serious danger of dying from their intoxication? So we need an alert system which can tell us that an emergency is happening. Now, we have these alert systems increasingly. In fact, I have an Apple Watch, and it was only the day before yesterday that while I was visiting Turkey, I went to look at I forget what the Turkish name of the mountain is with the fire, where the Chimera is meant to be. We were climbing there and I fell over and my watch alert went off to say it's going to send a signal that I've had a fall. Now, if we have the technology to do that, we should demand that that same technology is turned to whether it can detect whether somebody's had an overdose. And that's part of the work that my own group and others are looking at the moment. So we've been studying what happens during a heroin overdose. We have a clinical research facility, which is an inpatient, like an emergency ward, where research studies can be done. And we create small overdoses. We bring people in who are heroin users, and we measure what happens when they inject heroin. And we measure their respiratory function during those small, a micro overdose. And here's an example of some of the early readings that we took. And you can see that for the man on the left-hand side, in his session, this is his oxygen saturation levels. So they should be about 95%, or certainly more than 90%. And you can see that after his injection, it drops down to below 80 and then comes back up again. And the dotted line is a second session we did with the same man. And this was at the dose that he normally took as his regular dose. So we assume that this happens many times during his heroin use. And on the right, this woman was taking the same dose that she regularly takes, and you can see that again, her oxygen saturation levels drop to the low 80s and then come back up again. So we assume that this is what happens during a heroin overdose, and that it's just a more severe drop, and it doesn't come back up again. So our next level of work was to bring people in to our research facility and to stress it a bit further with a slight overdose to see what happened during an overdose. And let me explain these data to you. So in the top line, you can see this heroin user's regular breathing pattern. So this is 3 minutes of him breathing, and each of those lines, you can see a breath, and then a pause, and then the next breath, and a pause, and breathing at about 12 or 15 per minute. So that's a normal breathing pattern. And then the red line is his oxygen saturation levels at a stable about 95%. So that's a perfectly normal pattern. And down at the bottom is his carbon dioxide level, which fits those other patterns. So can you hold that in your memory, that that's a normal pattern? And I'll now move on to the next slide, which is what happens a few minutes after the heroin injection. And here you can see that there's a serious disruption to that normal, regular breathing pattern. And in particular, there are long episodes of no breathing at all. On this one, it's up to 30 seconds of no breathing, and then a gasp, and then the breathing drops off again, and another silent period. And if you look at the red line of the oxygen saturations, you can see that that is also all over the place. And we have had instances where the top line, the breathing pattern, we've had periods of a minute with no breathing at all. So this is what we're looking at, whether one could have a sensor that would detect that somebody might wear. And we're currently working on this with a company called Pneumawave, who've produced the sensor in the top left picture that you can see here, that is able to detect that the chest wall is not moving, that there's no rib cage movement, and it sends a signal to your phone and to the cloud. And having developed the sensor, we then want to test whether it accurately captures that on people who are currently heroin users. And that's the study we're doing at the moment, is taking a population of homeless people who are now living in hostels, but still occasionally using heroin. Can we detect instances when they have small overdoses or a more severe overdose? And assuming that that's reliable and accurate in its prediction, the next stage would be for it to be a real working project where it sent an emergency signal to the staff in the hostel to say that an overdose had occurred. In its future use, it may be that we look at the fourth box, that if there was no friend or family to respond to an alarm, perhaps it would send a signal about somebody's location directly to the emergency services. So this is work currently underway by my group, and other groups are doing similar studies, but we don't yet have a working product. Here's an example. Here's somebody wearing the chest sensor to give you an idea of how large it is. I've worn it for 24 hours, and it's comfortable to wear, but we still need to do lots of future work to check on its battery, its reliability, and its sensitivity and specificity. Okay, so that's all good. So we have an emergency alarm system, but what are we going to do? You know, if I'm the friend of someone whose alarms goes off, or if I'm a parent or a brother or sister of someone whose alarm goes off, and it tells my phone that my son or daughter or brother or sister have had an overdose, what intervention do I do? So we started looking at the area of non-fatal overdoses and how they were handled around the time that I became director at the National Addiction Centre. As you heard in the introduction, 25 to 30 years ago. And at that time, this was just of interest to us because we wondered what happened. And so we were documenting that there were these predictable features where we could identify who was at risk and when they were at risk. And then suddenly, you realize that we need to put this different information together. And as clinicians, we know that there are essential behaviors that must be done, like putting someone in the recovery position, rescue breathing. These are skills that we can teach people, and we would do it with a family of somebody who had epilepsy or diabetes or a severe allergy, but we weren't doing any of this teaching to the families and the friends of people who are heroin users. But also in medicine, we've got an extraordinarily specific antidote in naloxone, which completely reverses the effect of heroin and hence reverses an overdose. Anyone who's seen the film Pulp Fiction will remember the dramatic scene. I am aware that that's not a documentary film, but it captures the sense of emergency and the willingness to intervene in crisis. So overdose is the major cause of death amongst drug misusers, even when opiates are not the major problem. It contributes far, far more to the deaths for every 100 people involved with using it than other patterns of drug use. It's not the only cause of death, but it's the lion's share of deaths. We've also discovered that most other drug users who witness an overdose are very active in their intervention. They're very willing to intervene. They don't run away. They do lots of interventions to try and stop the death occurring. Sometimes what they do is the wrong thing, but that's in large part because we haven't told them and taught them about what the correct actions are. And in addition to that, We have an antidote which we've now used in emergency medicine for 50 years, which clearly we should be, like with adrenaline and an EpiPen, we should be using the same approach to giving naloxone, the antidote to opioid overdose use, to families, to drug users themselves, to people working in hospitals where there may be people still involved with heroin use. So this was first presented, so this was a sort of manifesto editorial more than 25 years ago now, arguing that there was a case for the distribution of naloxone to this population at risk. And soon after that, we began work surveying drug users about how acceptable would it be to teach them overdose management and naloxone training. And I'll just very quickly take you through the data here. I remember the shock from doing this study. So on the left, we have from the treatment sample. So I was shocked how many of the people that I was seeing had themselves had an overdose. So more than half of them had themselves had an overdose, and that almost all of these overdoses involved opiates, and they were usually in a home situation, either their home or a friend's home. And we found roughly the same in a community non-treatment sample as well. We then also explored about how many overdoses had they witnessed, and almost all of them had witnessed an overdose, including a quarter of them who'd witnessed an overdose in the last year. And we then also asked about whether they'd witnessed an overdose fatality. And nearly a third of them had already witnessed a death of somebody. They'd been there in a situation where the end result had been a death. We then went on to do some studies, and I don't think I kept the slides in here, where we asked, what actions did you take? And there were a lot of active actions, sometimes the wrong actions, but a clear high level of willingness to be involved with resuscitation efforts whilst waiting for emergency services. And in various parts of the world, we began to set up small take-home naloxone schemes where we would teach the emergency management of an overdose and also give people naloxone supplies. I'll skip through. These were some of the actions that people had taken, and there was a high level of willingness to make these actions. I'll skip through that. So we then began doing more widespread training and providing naloxone, and we then did a prospective cohort study following up some of the people that we'd done the training with to check how well had their level of knowledge improved and how much had their competence, their confidence improved, and then also whether they'd attended an overdose and what actions they'd taken. So we began a training program where we would be teaching people the ABC naloxone. So calling an ambulance, checking on the breathing, and then curling them into the recovery position, and then giving naloxone. And here we have how people's their knowledge improved about the risks, the signs, and the actions. How much did that improve from training? And we compared it with staff who also went through the training. And the first sobering observation was that our staff did not know any more than the patients they were treating. And also that our patients who we were treating their improvements were just as good as the improvements of our staff. So this showed what we were looking for was that it was perfectly possible to teach this population, and they would be able to improve their knowledge about the risks, the signs, and the actions. And the second learning from our point of view is we needed to do some education work with our staff. And if we look here about people's confidence about intervening, again, the columns with the diagonal slides is from before the training. And so after the training, you have nearly 60% being confident, nearly 40% being, 60% being very confident, 40% being confident. So almost all of the people at the end of the training, the users felt confident about intervening. We also then did some training work with family members, and that was a very powerful lesson from my point of view, that we were forgetting the family as an intervention group. And of the family members whom we interviewed, 20% of them had already witnessed an overdose, and 5 of them had already had a son or daughter who died in that overdose. And there was almost complete willingness, an active wish to receive training in how to manage an overdose and to be trained and given naloxone in how they would give naloxone if they needed to. Following that, Anna Williams, who was a PhD student working with me, then did her work looking at how did knowledge and attitudes then improve amongst family members who were trained. And Anna's subsequent paper, she did a randomized trial with a waiting list control where we compared how much did training improve people's knowledge and then improve their confidence. So in her trial, she had nearly 200 people, 200 family members who were randomized either down the left-hand side where they received the training, and then we'd measure how well their knowledge had improved immediately after the training. We'd then follow them up for 3 months to see how well they'd retained that knowledge. And on the right-hand side, that bit of the randomized trial was people where we were told we can't do the training with you until 3 months later. So we had a control group. And here you can see the red line is the control group, so that before the training, the control group weren't receiving any training, but their scores increased slightly, probably because being involved with a trial, they had then looked up about it on the internet. I don't know, but there was a slight increase. But if you look at the dark line, the group who received training, there's a huge increase in their knowledge scores. And when followed up 3 months later, they've still got that same much higher level of knowledge. And in terms of their confidence about intervening on the right-hand side, you can see the intervention group with the dark line. They are much more confident about intervening, and that's still there 3 months later. Following that, our government then introduced a training program about overdose management and naloxone, specifically for families and carers. Then, just over 10 years ago, Scotland became the first country in the world to introduce take-home naloxone as a routine part of the management of people with opiate problems, and especially of people coming out of prison. And you'll remember the prison data that I showed you a few minutes ago. And so there's a focus on that group. And across the whole of the UK, the law was then changed over the next year or two to allow any member of the general public to give emergency naloxone if it's for the purpose of saving a life. And around this time also, the US then became very interested in trying to develop a non-injectable. Might it be possible to produce a non-injectable nasal spray that the US was then interested in rolling out? And that generated work for the next 5 to 10 years. Also, policy organizations, so United Nations realized this is something that should become part of their national, their advice to different nations. And the World Health Organization published guidance on how countries should set up training schemes with overdose management and make sure that naloxone was available to family members, to other drug users, or to people working who might have any contact with people using heroin. More recently, the UN, the United Nations, has set up an initiative for much wider availability of naloxone. And I'll draw your attention to the bottom left, where there are these circles. So I'll take you through what is their 90-90-90 initiative. So it is that the objective for a country should be that 90% of people in the target group have received training in how to manage opioid overdose. And of those, 90% should have been given an emergency supply of naloxone as well. And that as a result of that, on 90% of occasions, when they are then present at an overdose in the future, they are competent and they get actively involved in the overdose resuscitation. So that sets objectives for policy and practice. I'm going to skip over these two. So one of the sobering observations from the World Health Organization work is that there were strong recommendations for the wider provision of training and for take-home naloxone, but I'll point out to you that it says the quality of evidence for these conclusions, for all of them, is very low. So we have weak science that needs to be improved. So the remainder of my slides are around trying to get stronger science into this field of overdose prevention. So first was with Rebecca MacDonald, who was doing her PhD with me. We did what's called a Bradford Hill review, which is a structured review of evidence where a meta-analysis is not possible. But it gives a discipline to examining the data, and it found that there was clear evidence that take-home naloxone programs reduce overdose mortality. Large studies were then undertaken. So, for example, in Massachusetts, Alex Wally and colleagues did a time series analysis looking at interventions in different parts of Massachusetts. Looking at the green line was how the overdose deaths were occurring in parts of Massachusetts with no intervention. And then the red and the dotted green line are for the reductions in those deaths in parts of Massachusetts where there were overdose training and naloxone schemes. From my own group, we were interested in looking at could there be other forms of naloxone. So just to remind you, naloxone used to be in the form of just a glass ampule, which is clearly not suitable or not appropriate for family or for carers or even for drug users themselves to be trying to administer in an emergency situation. So instead of these glass old-fashioned formulations, we then saw the emergence of pre-filled syringes. And here's a picture of one other one that's used quite widely across Europe and Australia. There were then pre-filled syringes, some of which had the needle already attached to them, which seemed a better arrangement to me. But these are all injectable, so none of them's perfect. And whilst they all work, they do assume that the people administering it feel comfortable about giving injections and that the kit is still intact. So we then became interested in, could it be non-injectable? Might it be possible to have a naloxone that, even though for 40 years it had always been an injection, we had done some work that looked as if you should be able to make a concentrated nasal spray, and so to have a non-injectable form of naloxone. And here's a picture of what it would look like. In the US, the FDA got interested in this idea and put out a call for proposals. And we then looked at, actually I'm going to skip through this so there's time for questions. Yeah, let's go through these two. Right. So we then worked with one of the manufacturers to test how a nasal spray would compare with injectable naloxone. And so we did a pharmacokinetic study in healthy volunteers, and we compared 3 different doses of concentrated naloxone as a nasal spray compared with either an intravenous or intramuscular injection. So we wanted to see, could intranasal naloxone, a nasal spray, could it be comparable to what we needed, which had always been an injectable nasal spray beforehand. And if anybody's wanting to look at the details, we then published them the year after we finished the study. And here's the graph of the pharmacokinetics of the different forms. And to make it slightly easier, I'm going to take you through each of these curves one at a time to explain what they are. So the grey one on the far left with a big spike is intravenous. So let's look at that. So here's what happens after intravenous naloxone. The plasma levels, there's a huge increase, and then it rapidly drops off and decays. But in fact, most emergency services, they give it intramuscularly, so you get almost the same shape as intravenous, but you don't have that spike. And ambulance services often say it's that spike that causes aggression from when somebody is suddenly woken up too abruptly, and that they think that the intramuscular injection, the blue line, is the one that they're aiming for. So we then compared the 3 different doses of concentrated nasal spray that we'd produced. So that was the low-dose nasal spray. There's the high-dose nasal spray. And here's the 2 milligram nasal spray, which became the commercial product Nixoid, which quite a number of countries around Europe and Australia and elsewhere now regularly use. But in doing this, we're wanting to look very much at the beginning, the first 10 minutes of those curves, because we need our naloxone to work in the first 5 to 10 minutes. It's not much use if it works half an hour to an hour later. So this was the basis of the naloxone nasal sprays. They had roughly 50% bioavailability. I'll skip over that. And so around the world, we've now got 4 different nasal sprays. Rather puzzlingly, different countries have very different doses, and it's not obvious yet why those doses are so different. So the US has a 4 milligram nasal spray. France went for a 1 milligram nasal spray. Most of the rest of Europe went for a 2 milligram nasal spray, and Norway has something intermediate at the low dose level. It will become clearer over the next few years, which is correct. These are the different nasal sprays which exist. And I think my final few slides are, could it be ultra-portable? One of the big problems we've discovered is that even though there's strong endorsement of take-home naloxone, there's very poor carriage rates. So often it'll only be 10 to 20% of people have it on them when you say to them, can I see your naloxone? And that's probably the same for what many of us would have if we'd been given it. We might have it at home, but not have it on us at the time that it was needed. So we've been looking at, could we develop an ultra-portable an ultra-portable form of naloxone? We're currently at the moment testing the feasibility of making a buccal tablet or wafer that you can put just inside your mouth that is instantly dispersed in about 20 seconds. And the hope is that this would be sufficiently portable that it could be in a credit card format that you kept in your wallet with you or your purse at all times, or maybe on a strip on the back of your phone. So this is work in progress at the moment. We've been able to produce this in our chemistry pharmaceutical sciences department. So we've been able to produce in the bottle on the right a prototype version of it with an adequate dose and with reasonably quick solubility. This is what it would look like. I'll skip over that. And here's what we hope the future product would look like, that one might have a strip of 8 of these naloxone tablets in a small paper container the size of a credit card. I'll skip over that. And so my final 3 points, let's go back to the 3 perspectives. So first of all, at a prevention level, we know that there are individuals at particular risk. And as with suicide prevention, we know it's people who've had a previous overdose are more likely to have a further overdose and also have a higher risk of overdose death. We also know that there are times of particular risk or settings of risk, such as coming out of prison, coming out of hospital, or coming out of rehabilitation, or ending your opiate substitution treatment. We need to remind ourselves that being in treatment is protective. So when somebody is wanting to stop their treatment, we need to warn them of the risk that there's an increased death rate in those first few weeks after finishing maintenance treatment. That in terms of detection, a lot of overdose deaths occur without people realizing that the overdose has occurred. And all of the new technology we have around wearables, we should expect that technology also to include detecting overdose. And then we have to work out what algorithm should there be, who should be alerted, how should that be managed, who owns that information. And then finally, in terms of intervention, we need to change our thinking about emergency management of an overdose or who gives naloxone, just as we do with management of an epileptic fit. If somebody in your friendship network or your family has epilepsy, you need to know how to manage them in the first stages of them having a fit whilst you're waiting for emergency services to turn up. So the idea of a wider intervention workforce and citizen responsibility, looking at what the wearable responses should be, better naloxone products, and a low-price, widespread pre-provision. So let me stop at that point and